I'm a clinician. I've been in practice diagnosing and treating Lyme for 30 years, dealing with patients, and it's amazing the stories and the compelling stories you hear.
Hold the mic closer.
That good? Okay. And the things that patients go through. Also, as membership chairman of ILADS, I interview doctors who are applying to ILADS, and one of the biggest things I find is these doctors are joining because they're treating patients conventionally and people aren't getting better. Then they get it or their family gets it, and they see the disability and the prolongation of the illness that Lyme could do, and they join ILADS for the educational purposes. And because the guidelines that have been in force are really outdated, and ILADS has new guidelines that are on National Guideline Clearinghouse website. I want to give the mission statement of ILADS because I think it fits in with the task force. It's to improve physician understanding of Lyme disease, to review and develop and implement programs and embrace the management of Lyme disease and associated diseases, meaning co-infections, viruses, Bartonella, etc. To advance the standards of care for Lyme disease and its associated diseases, and to review, develop, and implement programs for educating physicians and other healthcare providers. I wrote a little thing on ILADS guidelines just for you to look at. I think it's really imperative that we educate physicians on the concepts of Lyme disease. Knowing new concepts on the diagnosis and treatment of Lyme disease will give them a wider perspective in dealing with the many complications and the many difficult symptoms that patients have. ILADS does offer a fundamental course for physicians that's given on the day before our annual conference. I want to talk about some of the diagnoses so you have an idea of, and people have alluded to it. I want to give a case because it deals with what Senator Hemling and Senator Serino said. I had a 15-year-old young lady brought to me by her parents. She had a year and a quarter. She was an A student, and she had depression, severe depression, on 4 medicines, followed by a psychiatrist. I made the diagnosis of Lyme. She was positive for Ehrlichia, positive for Bartonella, but negative for Lyme. But I treated her with IV antibiotics for Lyme, and she's 90% better, and her psychiatrist has taken her off her medicines. The interesting thing is, when she was first in, and I said to her parents, as I was talking, what do you know about Lyme disease? They're from Connecticut. They're very well educated. And they say, we didn't know a thing about Lyme disease. So I thought that was illustrative. So Lyme disease is the great pretender. When I was in medical school, syphilis was the great pretender because it can cause neurological problems, it can cause rheumatological problems, it can cause cardiac problems, GI problems, respiratory problems. And the most important thing, hearing the health department and the testing, which I don't think is very satisfactory, Lyme is a clinical diagnosis. That patient is in front of you, and you look at the pattern of their symptoms, you look at the chronology of what they've gone through, and if it looks like a duck, walks like a duck, swims like a duck, it's Lyme disease. I mean, you know. So a negative ELISA, the Department of Health officials mentioned, the screening test does not rule out Lyme disease. I have patients who come in with months, years of symptoms, 2 or 3 negative Lyme tests. Their pattern looks like Lyme. They've been to a good number of specialists, very good specialists, had CAT scans, MRIs, etc. I make the presumptive diagnosis of Lyme disease, treat them, and the proof in the pudding is they come back after the first visit and they're 50, 60% better. And a lot of times they'll sit in your office and just cry because of what they've gone through. So I think it's really important for the panel to know that. Each patient, I treat each patient as a case history of one. I know we've learned in medical school double-blinded random control studies to find about treatments, but really when that person's in front of you, it's a case of one. And I've always learned about from a mentor of Lyme the statement that absence of proof is not proof of absence, and we're constantly looking to find the positive test. In fact, I see a lot of times people go to a physician with an EM rash, and they say, well, you know what, we'll just test you and see if it's positive. No, they have an EM rash, they have Lyme, you have to treat them. The ELISA test is only 49% sensitive. So that's like flipping a coin. And then what happens is when you send off an ELISA, and you should get a Western blot, that's called a two-tier system. But some labs, when you send off the Lyme ELISA and it's negative, they won't even do a Western blot. But even the two-tier system is not very accurate. We're seeing an increase in...
Do you have a testing system that you feel is more accurate?
Well, I use other companies, like I use a company in California, Hygienics, which, you know, I find is a little more accurate. I think what happens is some of the commercial labs, they do 1,000 tests, and they do 10 tick-borne disease testing, so they're not very focused on it. Where you go to someone who does a tick-borne lab, they focus on the accuracy of their tests.
And is eugenics accepted by Wadsworth or not?
I don't think so.
Okay.
No, they are covered except for a couple of tests that they don't okay, but most of them they are.
Okay.
But one of the things that Wadsworth does is, I as a New York physician, I'll go to a conference and I'll see all these tests. I'll come back to New York and I won't be allowed to do it. So for instance, Bartonella is becoming a big co-infection. There's a lab called Galaxy Labs that is a very good lab. We're not allowed to use that lab. There is a lab in Connecticut called Milford Molecular Diagnostics that does a DNA sequencing, very sophisticated testing for Miyamoto's disease. We're not allowed to use it in New York, so I think that's a really important thing that we have to correct. In terms of attachment of ticks and tick transmission, I have seen tick transmission in 6 hours, 12 hours. The literature has cases that are transmitted in 6 hours, so I think going for 24 to 36 hours can be very misleading to physicians. Oh, yours was only on 18 hours. That's it. Now, there are also guidelines. So the old guidelines are if you have a suspicious tick bite, take doxycycline, two caps. The ILADS guidelines is if you have a tick bite that's suspicious for Lyme disease, 3 weeks of doxycycline. I think the 2 capsules is erroneous method. So again, they did say this in the panel. It's important to know
2 capsules would be 2 days?
2 capsules, 1 time.
How many milligrams in a capsule?
100 milligrams. So it's really important to know that it's important to detect and treat Lyme disease, because the earlier you treat it, the best results you get. If you have someone who comes in a year of having symptoms, they're going to have a protracted treatment course. And Lyme disease, when it is there, can meld into symptoms of fibromyalgia, symptoms of chronic fatigue, and symptoms of chronic infection, and even autoimmune disease. So it's a really devastating disease. With respect to research, we need to do research on other modes of vector transmission, like how many pathogens are in mosquitoes, because they're also bloodborne, and also sexual transmission, because it has been shown to be in semen and vaginal fluid. So with treatment, my main tenets are clinically, you treat Lyme clinically. You use the test to support your diagnosis. And I do patient-centered care. In other words, what I've learned is you could see it in the clinic for 10 years and never have seen it in the book. You could study the book for 10 years and never see it in your office. So it's really important to have that person in front of you, that you take their full history, the chronological, their symptoms, who they've been to, what they're going through, and then do testing, then also treat when necessary. I wanted to discuss another case because Babesia was mentioned. I find Babesia is also becoming a big problem. And I do smears on Babesia, I do PCR, I do antibodies, and they're negative. I had a woman who was 42 years old, and one of the things you can get with Babesia is chest pain and shortness of breath and chills. And went to the emergency room 3 times, and 3 times was sent to the cardiologist, had 3 cardiology workups. I saw her. She had patterns which I thought were consistent with Babesia. I did the test, but I started treating her. She saw a physician, infectious disease, who called me and said, she can't possibly have Babesia. She's psychosomatic. The woman, after treatment for Babesia, has been well, and I see her every year, and she's doing fine. So now, and the third case I'd like to tell the panel is my daughter, who was 9 years ago, went to camp, came back without an EM rash, without a tick bite, developed a headache. We started treating with doxycycline. She didn't respond. Rocephin, IV. Then she developed autoimmune problems, which were treated with IV gamma globulin. And then I met with the neuro-ophthalmologist, the pediatric neuro, and her test had come back by the time she was in the hospital. She was hospitalized for 3 weeks, lost part of her vision and movement of her eye. Her test came back positive for Ehrlichia, but negative for Lyme. But when I sat down with the infectious disease, I said, this implies Lyme disease. The symptoms are definitely Lyme. And she took 10 weeks of IV antibiotics and was better. But what happens is when patients get into that, often the insurance company says 4 weeks of antibiotics, no more, and they are left in a lurch. They don't know what to do, and you don't know how many times that happens. Sorry.
Hopefully it's not a patient.
Nope. Okay, so I'm open for any questions if we have time.
What are the tests for Babiosa and Ehrlichia that are different than the test for Lyme?
Well, Babesia is a parasite, and so you can do antibody testing, which shows the history. You can do a PCR, and you can do what's known as a Babesia fish, which is a test that I often find very good to use, which IGeneX does. And then you can also do a Babesia smear. I find a Babesia